big problem in our country.
Thank you very much. As you rightly say, the diabetic foot in this region is extremely prevalent, and most of the cases that I see in the Middle East region tend to be neuropathic in etiology. So let me start with a quote from Voltaire. And Voltaire wrote these words. He said that the art of medicine consists of amusing the patient while nature cures the disease. Now, that may be true for some diseases, but certainly not for diabetes, and certainly not for the diabetic foot. And this is a lady that I met when I first arrived to Manchester as a physician consultant some 31 years ago. And clinical observation teaches us a lot. On this pointer doesn't work, so I can't point, but she can't focus very well because she's blind because of type 1 diabetes and diabetic retinopathy. There's a patch just to the right hand above her nightie there for the delivery of nitrates for her ischemic heart disease. She's got a scar in the center from a coronary artery bypass graft. She's just started peritoneal dialysis. This is 31 years ago. And she's got no legs. And she's 45 years old. Now, as I told you this morning, or earlier today in the first lecture, the outlook for patients such as this is worse than almost every form of cancer. 75% of people like this are dead within 2 years. So we have to take diabetes seriously. And she said to me, take this picture, because I don't want other people to end up like me. Can you do something to prevent the terrible late complications of diabetes? So what we're talking about is preventing amputations in diabetes, if at all possible. Let me give you some stark figures just published this year from the United Kingdom. £1 in every 140 of total National Health Service expenditure is spent on the diabetic foot. £1 in every 140 on the diabetic foot. Foot ulceration and amputation cost the National Health Service more than £1 billion. Multiply that by 25 for Egyptian pounds. And 2/3 of this sum is for treating foot ulcers in primary care and outpatient settings. So, where have we been successful and where do we have to do more? Well, we do know the causes of foot ulceration, and these come from good, properly conducted prospective observational studies. And we know that people in each of these groups is at increased risk of foot ulceration. Those with neuropathy, those with peripheral vascular disease, most at risk of all are those with a past history of foot ulcers or who've already had an amputation. Even in the best centres, if you've had a neuropathic foot ulcer, you've got a 30 to 50% chance every year of having another one. Very bad. If you've got microvascular complications, especially diabetic nephropathy, and I'll refer to this in my talk on nephropathy tomorrow, poor glycemic control, smoking, foot deformities, and, as I've said, amputation. Now, it was Dr. Paul Brand who worked in southeast India in Tamil Nadu, who I was fortunate to know. I first met him in Madras, now Chennai, in 1985, where we were looking at the similarities in foot problems seen in leprosy, la lepre, Hansen's disease, and diabetes. And he said, quoting patients with leprosy and also with diabetes, pain is God's greatest gift to mankind. And the problem is that those with a dense symmetrical polyneuropathy have lost the gift of pain. So the consequences of diabetic neuropathy are multiple. This is just the chronic sensory motor neuropathy. I haven't got time to discuss autonomic neuropathies. If you wish, we can discuss that in the workshop later on. It's true today, if you know diabetes, you know all of medicine, because diabetes encompasses all of medicine. The clinical consequence is at one end of this spectrum, you've got people who've got a very painful neuropathy, who can't sleep at night, allodynia, which is when a non-noxious stimulus gives rise to a painful experience. The pain's worse at night, it's burning, difficult to describe. At the other end of the spectrum on the right, you've got patients who've got loss of the gift of pain. They're at risk of foot ulcers. Most people have some symptoms and some signs. And the signs can only be detected if you examine the feet with shoes and socks removed. So how do we assess for neuropathy? Well, the first thing, I can say is that you do not need any expensive equipment. The most important thing is to look at the feet with the shoes and socks removed. We can use simple tests. Can you feel the pressure of a monofilament? Can you feel vibrating 128 Hertz tuning fork, pinprick, ankle reflexes? We don't need quantitative sensory testing or electrophysiology, a complete waste of money. And Paul Brand again said you do not need any expensive equipment to diagnose the at-risk foot. Now, we showed in papers more than 35 years ago a clinical sign of diabetic neuropathy is these distended, and I can't point, dorsal foot veins. It would be nice to have a pointer tomorrow that works, by the way. Distended dorsal foot veins, you can see there. That's a sign of peripheral sympathetic autonomic neuropathy due to release of vasoconstriction. And we showed you get arteriovenous shunting. So this clinical sign we described in 1983, I think, if I remember. And the year before, I published a paper in the January edition of Diabetologia showing that if you take blood from these distended dorsal foot veins, it's arterialized because of arteriovenous shunting. This is the paper. The neuropathic diabetic foot is warm because of increased blood flow if there's no vascular disease. Dilated foot veins are a sign, and venous PO2 is elevated in those with a history of foot ulcers, compatible with arteriovenous shunting. In the same issue, a few pages after my article, was another paper by Mike Edmonds, my good friend from King's College Hospital in London. And this really was symbiotic. It added to what we showed, and he showed that using non-invasive Doppler studies that the results of pulse wave velocity, pulsatility index, was compatible with arteriovenous shunting. So, the warm but insensate foot is truly the at-risk foot in patients with diabetes, particularly in this region. In the UK now, we're seeing more neuroischemic ulcers because of our mass screening, and then primary care physicians get reimbursed if they screen the feet. We're not seeing so many purely neuropathic ulcers. There are easier tests. The Ipswich touch test couldn't be any easier. This is the Ipswich touch test. Can you feel the touch of a finger on the toes? Couldn't be more simple than that. Without pushing. And this can be used, and most of our nurses have 5 fingers on each hand, so they can do that test very easily. And this is just as good as the monofilament in this paper published in Diabetes Care by my friend Jerry Raymond from Ipswich. So he showed that the Ipswich touch test and the monofilament are almost in perfect agreement. And the health authorities love this test because it doesn't cost anything. It's free. Then there's the VibraTip. I have one here in my hand. It's a very simple tool. It's a pocket-sized, wipe-clean, battery-operated disposable device for checking vibration. Here it is. And here it is in the hand, so you can see. On the left-hand end, in here, there's a small battery. You squeeze this, and it causes a vibration at the tip. And the good thing about this, it's forced choice methodology. The patient cannot tell if it's vibrating or not by looking at it. And they can't hear it like you can hear a tuning fork. And in a study we published a few years ago, we showed in a study of 80 patients that the correlation was excellent between the other standard tests, including the Ipswich test and neuropathy disability score and the gold standard of biaesthesiometry or vibration perception threshold using quantitative sensory testing. Some of my early research working with Professor John Ward in Sheffield, and later we had a gate laboratory in Manchester, we showed the importance of increased pressures and loads under the neuropathic foot in diabetes. High foot pressures predict ulcers, they're a risk factor, and we showed in a number of studies that these high foot pressures in the insensitive foot, because of repetitive pressure, leads to callous, hard skin, which acts as a foreign body and causes ulceration. But more recently, working with my friend and colleague, Professor Neil Reeves, Manchester Metropolitan University, they have a gait laboratory where you can assess gait not only walking, but going up and down stairs. Now, if you think about it, most trips and falls occur when you're climbing or coming down stairs, usually descending. And these may contribute, because of repetitive stresses, to the genesis of the Charcot foot in neuropathy. So we've done a number of studies where we can, using a camera system, there's Professor Reeves, tagged up with reflective markers, so we can look at gait, not only walking along the level, but up and down stairs. And I'll quickly go through these. This is kinematic and kinematic data, looking at walking and ascending stairs. The role of muscle power development, or torque development, peripheral neuropathy with sensory loss, there's a delayed neuromuscular response. And what we showed here, that if you look at the knee is in blue, the ankle is in red, on the right of each panel is the neuropathic diabetic patient, and on the left is going upstairs, on the right is coming downstairs. And you can see there is delay in every case in the role of joint torque development in patients with diabetes. Then we said, how accurate are people walking? Altered visual gaze behavior. They're slower to acquire the target and they're less accurate. And then we looked at balance. Now, the best way to show you balance is to show you a movie. And this was published a couple of years ago, looking at the center of mass minus the center of pressure. And the more unstable you are, the wider that'll be. So here on the left is a non-diabetic individual coming down the stairs. And on the right, you see a patient with neuropathy. Look at the sway. Look, these are unstable, slower gait. They're more prone to fall. And we were able to quantify this and publish these data. Or we looked at the metabolic cost of walking using VO2. Perception of difficulty, slower walking speed, and this has influence on physical activity. And again, we showed the diabetic neuropathy on the left of each column. Again, metabolic cost for walking is higher. So to summarize, mechanisms underpinning falls in diabetes is the rate of muscle force development, visual gaze, and balance. It's a higher metabolic course for those with neuropathy. And the Achilles tendon may be tight, and that may affect it as well. And this, with muscular impairments due to a motor neuropathy, a sensory motor neuropathy, contributes to the common trips, falls, and even foot ulcer development. So this is the pathway, a simplified pathway, to neuropathic foot ulcer. The top, you've got diabetes, somatic sensory neuropathy, somatic motor neuropathy, and autonomic neuropathy. And this leads to decreased pain, as I've said, deformities, increase in foot pressure, small muscle wasting. On the autonomic side, decreased sweating, dry skin, prone to develop hard skin, callus. And this can lead to foot ulcers, the at-risk neuropathic foot and foot ulcers. In green is what the patient can do about it. On the left, can they reduce what they're suffering because of the loss of the gift of pain? They can by examining the feet, wearing sensible shoes, bottom left. Not doing your own foot care at home with a scalpel, as some patients like to do. I saw a case yesterday. A patient had developed a blister, so he got a dirty pair of scissors and stuck it into it. And just walked into the clinic yesterday morning in Manchester. Entirely preventable. On the right, you can moisturize the feet, have regular podiatry. And of course, if you've got an ulcer, it's important that you follow the advice to wear some off-loading device. A junior doctor said to me, that patient's so stupid. Look, they've got a huge neuropathic foot ulcer and they're walking on it. I said, no. The patient is not stupid. You're stupid. Because you don't know what it is not to feel pain. We limp when it hurts because it hurts, to offload the painful area to reduce inflammation. These patients continue walking on it and they feel great. So you have to remember the loss of the gift of pain. Now, in terms of education, H.G. Wells wrote these words. He said that human history becomes more and more a race between education and catastrophe. And we see the catastrophe in the diabetic foot clinic of education failing. So can I prove to you that education alone reduces the incidence of foot ulcers? Sadly, I cannot. I can't prove it. Here is a systematic review from the Netherlands, from Utrecht, of primary prevention of foot ulcers, and it shows that there is insufficient robust evidence to support education alone in the reduction of the incidence of foot ulcers. Too few trials, poor design, insufficient follow-up. But we must interpret this as lack of evidence, not evidence of no effect. I'm sure that education does have a place, I'm 100% sure, but I can't prove it to you. That's what I'm saying. And here's another population base for primary prevention. Again, a systematic review from London. Again, interpret as lack of evidence, not evidence of no effect. We can't prove it. What about the team approach? Well, again, Jerry Raymond's group in Ipswich have showed that in the 11-year prospective study, where they introduced a multidisciplinary team approach with podiatry, regular foot checks, education, good shoes, and so on, and they were able to show a 70% reduction in amputation in their region. I can't prove it's education alone, but the combined effect of the team approach does work, and there are other data to support that. If you've had an ulcer, what about secondary prevention? These data from my friends in Nottingham, and they took patients with newly healed foot ulcers and randomized them to a usual care group or intensified education by general practice. So the intensified education had a group session showing them what to do, how to prevent recurrent ulcers. Although there was better reported foot care in the intensified group, they couldn't show a reduction in amputation or recurrent foot ulcers. Now, I believe that these patients, education alone does not work because they're too physically impaired. So you need some intervention the patient can perform, and one comes from the original observation again of Dr. Paul Brand. And he showed that before a foot breaks down, now on the right you can see those heels have probably been lying on an orthopedic surgical ward and the nurse didn't realize they had diabetic neuropathy and they haven't turned them. That's about to break down. What he showed is that before the foot breaks down, it warms up. Inflammation. So, could we stop nerve damage plus mechanical stress, the foot warms up? Is this a sign of about to ulcerate? So can we intervene there? So this was a study done by my good friend Larry Lavery from Dallas, NIH sponsored. And he had patients either have the structured care, was the green line, the standard therapy was the structured care is the purple line. The standard of care was the green line. Standard of care was good. These are patients who had a history of foot ulcers. They were randomized to one of three groups. Standard of care, podiatry every 2 months, good footwear, regular podiatry. Enhanced care, the purple line, they had all that, plus they were given a mirror on a stick and a notebook, and they checked their feet each day because patients in Texas tend to be rather large. They might not be able to see their own feet. So they have a mirror so they can examine their feet on a stick, and if they found something worrying, they were told to contact their podiatrist. The group in the red, the top line, they were given a self-temperature monitoring, a little thermometer. They checked the skin temperature on both feet twice a day. If one foot was warmer than the other by 1.5 degrees Celsius, they were told to rest and see their podiatrist. Now that's education plus an intervention. The patient felt one foot was warming up before it breaks down, they didn't walk, and it reduced ulcers by 30%. So there is a possibility. What about treatment? Well, first of all, we need to classify. There are many classification systems. One is the Wagner system, which is tried and tested for many years, from the superficial grade 1, deeper grade 2, grade 3 probes to bone with osteomyelitis, grade 4 is localized gangrene, grade 5 in the middle, bottom is gangrene whole foot. And on top of that, we've got the University of Texas and many other systems. Now, I think a diabetic foot will heal if you let it. I don't think I know. A diabetic foot will heal if you let it. If there's good arterial inflow, we're getting much better at distal bypass surgery. If any infection is appropriately managed, we're getting good with multiple antibiotic therapy, intravenous perhaps. And you remove pressure from the margin and the ulcer itself. We're least good at that because we cannot conceive that someone would walk on a foot ulcer. Now, this is a lady that came to see my nurses many years ago, and she didn't come to see the nurses because of this nasty lesion on her foot. She came to see the nurses in the early days of blood glucose monitoring. My blood sugars are high. So the nurse appropriately altered the insulin. Then before she left, she said, "Oh, you better look at this spot on my foot." The spot on the foot was due to a rusty nail having gone through the third metatarsal head region. She had osteomyelitis in the proximal part of the proximal phalanx. She had an interphalangeal third MTP joint septic arthritis, and she had involvement of the distal third metatarsal. The key question here for management, she's got infection, we treat that aggressively, intravenous antibiotics. We control the diabetes, intravenous insulin. The key question here is the circulation. She had an excellent pulse, normal Dopplers. So we can get away with local surgery. Now, there is increasing evidence, as we can discuss if you wish this afternoon, that local osteomyelitis in one bone or two in the foot can be treated by antibiotics alone. But usually if you've got a septic arthritis, you need some form of surgery. And it was Dr. Robin Lawrence, who founded the British Diabetic Association, who originally had type 1 diabetes, one of the first people in England to receive insulin, that saw a case like this during the Blitz in the Second World War. And there was no consultant around, so he told the surgeon, he drew a cake. He said, cut a slice out of the cake. And that's cutting a slice out of the cake. Now, you'd think this is awful. It's not going to heal up. Well, that's a few weeks later. The diabetic foot will heal if you let it. Intravenous antibiotics, take away the infected part, and don't walk on it. And it healed up. This is the kind of foot I show to a medical student, and they don't see that there's a toe missing, because it closes up. So you can heal the diabetic foot. But there are many problems in clinical trial design that have led to many of the newer therapies really having failed in clinical trials because of the people that did the studies did not take into account of confounding variables. Most important of all is offloading. A classic study when I was working in Miami in 2002 appeared in the American Journal of Surgery for Promogran, which I think is probably quite good. But the study showed it was just as good as saline gauze, which cost about 1/50th of the price. And they said offloading was left to the individual. That means they didn't do any offloading. Activity. Can you compare someone like you who is sitting here all day with someone who's working as a conductor on a train walking up and down all day? Can you have those in the same trial? How much day do you spend walking, sitting, standing, etc.? Weight, BMI, footwear, adherence, climate. Can we have a controlled trial looking at new therapies for diabetic foot ulcers with a batch of patients in Cairo and another batch of patients in Helsinki? Maybe plus 30 here and minus 30 there. All these things we need to think about. What about dressings? Dressings do not heal ulcers. They give false reassurance into the covering an ulcer they were healing it. Not true. A dressing is really not helpful in healing ulcers. It's just to keep the wound clean. There is no evidence to support the use of any particular dressing, and here's my friend William Jeffcoat, who did this randomized controlled trial of 3 dressings. NA is not adherent, Inidine and Aquacel. Well-designed study that you could find no difference in outcomes despite the dressing being used. The only difference was one dressing was 3 times as much as another. Here's a systematic review published in 2012. Evidence of poor quality. More expensive dressings do not offer any obvious advantages. What about negative pressure wound therapy or vacuum-assisted closure? Now, this was developed in the United States 20, 30 years ago and leads to wound contraction, neoepithelialization, and it removes gunk or exudate, infectious materials. There are 2 randomized controlled trials, not perfect. There are problems with these trials, but there at least is some evidence that negative pressure wound therapy helps. This was a multi-center trial in the USA, published in The Lancet 2005, where they randomized patients with local surgical treatment to a VAC or standard of care. And they showed more rapid appearance of granulation and rapid healing in the VAC control group. A later study published again in less complex foot ulcers, those who didn't respond to standard of care, offloading, antibiotics, etc., they showed that those who had negative pressure wound therapy were more likely to heal and there were less amputations. So some evidence. This is the old VAC used in those studies. You have a seal around the wound, the sponge, and you apply a negative pressure of 130, 120 millimeters of mercury for 23 hours a day, and it removes all the exudate and it stimulates granulation tissue in this first ray amputation, and you can see the result after a few weeks of VAC. If anything, hypergranulation. So this is a useful non-invasive therapy when used appropriately, and you don't need it in the routine neuropathic foot ulcer. What you need to do there is offload, and I can talk about offloading in the workshop if you wish, because we've shown that it works if you actually wear the offloading device. And a series of studies from my Miami group. And what about hyperbaric oxygen? Who uses hyperbaric oxygen here? Anybody? Well, that's reassuring because it's useless. Anyway, here's some studies. Look at the rapid growth of hyperbaric oxygen in the United States. More than 1,000 chambers today. More than 1,000 chambers. So it must work because it's reimbursed. Well, we know hyperbaric oxygen leads to local vasoconstriction. It's good for edema, increased fibroblast proliferation, angiogenesis stimulation, leukocyte killing, recruitment, and synergizes with some antibiotics. But it's been used to treat almost everything under the sun or under the clouds. And, leprosy. It must be a good antibiotic. And this is just a small list. And of course included there are diabetic foot wounds. So where's the evidence? Well, most of the studies of hyperbaric were originally used case series, case reports, and cohort studies, but I would suggest to you they're useless. What we want in the diabetic foot is no longer, I've done 6 cases and it works. We want, here is the evidence, so randomized controlled trials. Now, I'm a senior associate editor, have been for heaven knows how many, 16 years, for diabetes care. And this study came our way in 2010 from Magnus Londahl, who I know. And this was a good study, well designed, from Sweden, a placebo-controlled, double-blinded, randomized controlled trial of chronic neuroischemic ulcers. 5 treatments per week, up to 40 sessions, or dives. And they showed complete healing was more likely in those who received hyperbaric oxygen. It may therefore be an adjunctive, useful therapy in those who've got neuroischemic wounds that can't be revascularized and are not getting better. So it's a very small group. But for some reason, the change wasn't seen until 9 or 12 months after the treatment. But we accepted this paper, well designed and published, and I took an editorial to go with it. But then Dave Margolis, who's an epidemiological dermatologist from Philadelphia, he looked at the efficacy of hyperbaric oxygen for diabetic foot in a huge wound care network of 6,259 patients. And what he showed in this study was that hyperbaric oxygen patients were actually less likely to heal and more likely to undergo amputation. Even accounting for confounding variables, they're evidence. And then the Canadians thought, well, let's try and replicate. These are hyperbaric oxygen experts from Canada. Let's try and replicate the study from Sweden. And they did a multi-center randomized controlled trials on a good number of patients, chronic diabetic foot ulcers, 30 daily 90-minute dives or treatments with hyperbaric oxygen or hyperbaric air. And they couldn't show any difference whatsoever. And this was published in Diabetes Care last year. No difference in any outcome. Hyperbaric oxygen did not reduce major amputations requirements as compared to best practice. No difference in healing rates or the number of healed wounds. No difference in quality of life. No evidence. So what's wrong with hyperbaric oxygen for diabetic foot wounds? Quackery. Sounds good. Possibly. Evidence of efficacy? Minimal. Effectiveness? Little to none. Resource allocation? More bangs for your buck or your Egyptian pound elsewhere. So then we thought the Dutch might give us the answer. And this was a study, this was the publication in the Journal of Diabetes in 2015, telling them about this trial, the Damocles, the sword of Damocles, hanging over the leg. They called it the Damocles study, and it's the largest ever study, run in the Netherlands, and they took ischemic ulcers, and the results, they said, will be ready in 2005. The results were just published a few weeks ago. Completely negative. Damocles study, oops, it's negative. It was presented at the VEITH Symposium in New York last November. Hyperbaric oxygen did not significantly improve wound healing or limb salvage in diabetic ischemic wounds. So I'd caution you, it's very expensive, and I am a cynic. So I said to the people at hyperbaric, actually, hyperbaric oxygen is probably a very good way of offloading the foot because you can't walk around inside the chamber. But it's rather expensive. So I think, talking to the future, we need proper guidelines on clinical trials. What should be the endpoint? Should it be percent healing at 6 weeks, 12 weeks? Should it be total healing? Granulation? What's the standard of care? Should it be in the control group? We need proper design of clinical trials. What's the length of follow-up? Londahl study, 9-12 months. Inclusion-exclusion criteria need to be standardized, stratification, footwear, and so on. There are dangers of prophesying. Here people who have not done so well. Radio has no future, somebody said in the 1930s. X-rays will prove to be a hoax. There is no future for guitar bands, said Decca Records in 1961. I think there may be a world market for 5 computers, said Thomas Watson, 1943, chair of IBM, and yet there are probably more than 5 computers in the front row. So there are dangers of prophesying. But I think the future, we've had lots of systematic reviews and Cochrane analyses. I think these really need to be done not by people who are looking for an extra publication, but people who actually know the field. And many of these systematic reviews are done by people, looking for something to do. Randomized controlled trials must use expert centers, not ones who want $5,000 per patient and will enroll as many as you want. Agreed standards of care for the control arms of studies, agreed endpoints, internationally agreed guidelines on the design of trials. And this may be through the International Working Group on the Diabetic Foot Study Group, the ADA Council, and so on, working together to come forward. But until then, we need to work together as a team, because each of the members of this team may think that someone else is looking after the foot when actually nobody is. And this is an order of alphabet. The diabetologist is probably the least important in the team. Most important, I would suggest to you, is the patient, the nurse, the podiatrist, and the shoe fitter. So I'll leave you with this a quotation from Professor John Lindsay, who was Professor of Medicine at the University of Belfast 100 years ago, and his medical students had to learn all his aphorisms. And in terms of the diabetic foot, he's absolutely right. For one mistake made for not knowing, 10 mistakes are made for not looking. And most diabetic feet, you can identify the high-risk foot, removing the shoes and socks, and looking at the feet. Shukran. We're going to have a workshop anyway, so we can discuss that.
This was a very, very elegant talk, Professor. The quality of your slides are perfect. We really enjoyed it. We have two suggestions now, okay? Either we take one question or two questions for each speaker, or we postpone it all for the workshops. What do you suggest? Is it lunch or questions? Would you like to ask questions and...